Good morning, ladies and gentlemen, again. So it's the pretty tough topic, honestly. So 15 minutes again. I do not have anything to disclose. Again, that here I will not go over everything. I will focus on the issues that need discussion and explanation. Okay. So what I would like to do is to revisit the definition. I wanted to go over the outlet septum a little bit, which is also called as an infundibula and corner septum. And then in the intermission, I was asked opinion about the tau C being malformation. I have some different idea about tau C being malformation, honestly. And then there is some debate on the outlet septum, deficiency of outlet septum, absence of outlet septum, automatically define that VSD is doubly committed. That's wrong, okay? I will explain why it is wrong. And then remote VSD, how do you need to define remote VSD? And then what about the AVSD and DORV? Okay. So definition, I think everybody agrees both great arteries are rising either entirely or predominantly from the right ventricle. Okay. It is a form of ventricular arterial connection. You can have it underlying heart in many, many different ways. Therefore, it is not defining the pathology itself. It is just a single part defined. I show you this the drawing. I have a lot of credit on this because in the Googling, who really described the double artery right ventricle first. And I find that the textbook is right. John Abernethy described this heart 1793. Look at this drawing. It's unbelievable. It's the open right ventricle. You have tricuspid valve, and this is the VSD here. This is open aortic valve. This is the pulmonary outflow tract, small pulmonary artery. Okay. It is better than our 3D modeled and 3D printed heart. This drawing is so clear. Here, if we look at the infundibulum and VSD, it is TOF, even if it is almost 100% overriding. But however, by looking at the ventricular arterial connection, it is DORV. What I mean is that TOF and DORV are not mutually excluding the exclusive terminology. You can have a TOF, if it was more than 50% overriding, you have DORV too, okay? Don't discuss that in the conference. Whether it's DORV or it's TOF. That is the beginning of unnecessary debate. Okay. Definition of tetralogy of Fallot was actually introduced by Dr. Abbott, who is the fellow Montreal pathologist. Okay. And then she described that this gentleman described 4 different aspects of one pathology, and then she named the disease as tetralogy of Fallot. I would give credit to this gentleman because that drawing is clearly tetralogy of Fallot, which is that he passed away before tetralogy the Fallot was born. Okay. Anyway. So we know that we use that 50% rule to define DORV versus VSD, which means that this is very arbitrary. That's why here's my previous fellow here too. I make a joke in the morning that Dr. Chung comes to me, whether it is DORV, and I say DORV. But however, the Chang Ali comes the next hour, come to me as a VSD. I say it's VSD. What it means is that this is a very arbitrary definition. We need to understand that. And then here, another thing is that lower margin of the VSD is clear, no controversy at all. However, upper margin is open. There is no septum. That's where that definition of VSD is stalled. Okay? So somebody wants to call this is VSD, somebody wants to call this is VSD, this is VSD. Controversy. I'm discussing with Robert Anderson for more than 20 years about this. And then I'm asking Bob Anderson, please do not try to define which is not definable. Upper margin of the VSD is simply not definable if you have overriding aorta like this. Okay. Anyway, What is outlet septum? Outlet septum, also known as infundibular septum or corner septum, is simply the dividing wall between the subaortic and subpulmonary outflow tract underneath the semilunar valve. In normal, that is between right and left ventricle. But in tetralogy of Fallot and double outlet right ventricle, outlet septum is not interventricular anymore. Interestingly, outlet septum is a part of ventricle, but however, it respects semilunar valves more than ventricle, right? What it means is that outlet septum is simply below the junction between aortic and pulmonary valve. Okay? So although it belongs to the ventricle, it respects arterial valves. That should be clearly understood. Okay? And then ventricular infundibular fold, what is that? So here in the normal right ventricle, you have pulmonary valve above and tricuspid valve below. You have a fold of muscle here. So the previously described as crista supraventriculis roughly, and then using that some interesting terminology, ventricular infundibular fold. What is that? A muscular fold or inner heart curvature that separates an arterial from an atrioventricular valve at the base of the ventricles. Actually, it does not describe the lateral boundary clear enough. But however, we usually understand that. So this Y-shaped structure, trabecular septum marginalis, so-called anglicized terminology, septum marginal trabeculation. And then you have a so-called outlet septum here. So between this and this, that is the boundary. But boundary is not very clear, even in normal heart. Okay. So what is infundibulum? If you have a ventricular infundibular fold, this ventricle has infundibulum. What it means is that if outflow tract is a 360-degree muscle, then you define that this heart has infundibulum or corners, this ventricle. Like a normal ventricle here, if you have aortic valve and mitral and fibrous continuity, your outflow tract is no more 360-degree muscular. And then you say this ventricle does not have infundibulum, does not have corners. Okay. Having said that, presence of infundibulum or absence, we are using very different terminology, but we are talking about same thing. So what it means is that here you have a discontinuity between semilunar valve and atrioventricular valve. And discontinuity. Here you have a continuity. Actually, you are talking about same thing, whether you have an infundibulum or not infundibulum. Okay. Second, presence or absence of crista supraventriculis. You have crista supraventriculis, which means that infundibulum, there is infundibulum. If you don't have a crista supraventriculis, there is no infundibulum. Okay? Ventricular infundibular fold, exactly the same thing. So what I'm talking about here is that using all different words, actually we are talking about exactly the same thing. Okay. Having an infundibulum, especially to echocardiograph or MRI imagers, this is important. If you have an infundibulum like this, you should have a ventricular infundibular fold. If you have a ventricular infundibular fold, what is going to happen? Semilunar valve should be pushed forward or upward, right? So therefore, if you see that semilunar valve just right next to the chest wall, you right away think that that semilunar valve will be supported by muscular infundibulum. Okay? So that is a very simple rule. But how much, we don't have criteria for that. Okay. So therefore, types of infundibulum, you have many variations. So like normal, you have your the pulmonary infundibulum, no subaortic, and then here, this is aortic valve, like a transposition. You have subaortic infundibulum, no subpulmonary infundibulum. Here you have both, and then here you do not have any, right? You have 4 variations. In double outlet right ventricle, I wouldn't say the majority, that more than half, more or less a majority, we're going to have bilateral infundibulum, not always. Okay. So let's revisit what the double outlet right ventricle in this drawing. So if you have a double outlet right ventricle, outlet of VSD is actually outlet of the left ventricle. okay? Only outlet, if you have a 200-degree override, the arising from RV, that is the case. And then, as I discussed, outlet septum is married to aortic and pulmonary valve. It is always underneath. And then, outlet septum is no more interventricular. Outlet septum is exclusively right ventricular structure, okay? Here, I would suggest to surgeons confuse the Bob Anderson tremendously. Why? So surgeon describe here repairing, you patched the VSD. Actually, you didn't patch the VSD. You baffled the left ventricle, the patent left ventricle outflow tract using the low margin of VSD and using the outlet septum. You didn't patch it, you baffled it, right? So when you have your semilunar valve and AV valve separate with the muscle, that is called ventricular infundibular fold, okay? And then when you have a ventricular infundibular fold, you have muscular infundibulum here. Okay. So this is a well-known classification about DORV, 4 different types. DORV with subaortic VSD, DORV with subpulmonary VSD, DORV with doubly committed VSD, DORV with remote VSD. Don't forget, the description was 1972, which is more than 50 years now. So the VSD, the DORV classification would not be this simple. You have a lot of different variation, not actually belonging to each of these, not completely. Okay. So here, whenever you have DORV, at least you need to describe these 5 modifiers. VSD location within the ventricular septum with predominantly inlet or predominantly outlet or inlet and outlet. And then perimembranous versus non-perimembranous VSD, which gives you full insight on the conduction axis. And then orientation of the outlet septum, in imaging especially, very, very important. And extent of infundibulum also is important. Why? Let's say VSD is extending toward the outlet, and then you do not have a subaortic infundibulum, and then VSD will be immediately below the aortic valve. However, with the same location of VSD, what if semilunar valve is supported by long infundibulum, and you will have significant distance between upper margin of VSD to the semilunar valve, right? So that's why extent of infundibulum is also important. Great arterial relationship. The last question, in the last session was on this, and this is important too. Okay. So here that I can't go over everything. I will talk about the orientation of the outlet septum here. So this is drawings as just the outlet aspect of the heart only. Okay. So you have a VSD. This is aorta. If the outlet septum goes to the left margin of the VSD, the position isolates pulmonary valve from the VSD, and VSD is automatically below the aortic valve, right? In cross-sectional imaging, understanding of this concept is very important. And then if you have similar VSD, however, outlet septum goes to the right margin of the VSD, and then that VSD becomes automatically below the left-sided the semilunar valve, and the right-sided semilunar valve is isolated. Right? Another variation not very well described in the pathology literature is, but however I frequently see, is that outlet septum can be just forward, away from the rest of the ventricular septum. They are parallel. Okay? And then VSD is below the posterior semilunar valve. So that is what outlet septum parallel with the plane of VSD. And then, if the infundibular septum is long, or the infundibulum is long, and then you can have outlet septum not related to right or left margin of the VSD, relative free floating. That makes this VSD remote from both arterial valves. Okay. So here I'm showing 2 different cases with subpulmonary VSD. Here, in this case, this is a tricuspid valve. You have your trabecular septum marginalis, posterior limb, anterior limb. VSD is cradled between anterior and posterior limb. And then outlet septum goes to where? right margin of the VSD, making this VSD below the pulmonary valve, nothing to do with the subaortic outflow tract, right? Outlet septum inserting to the right margin of the VSD. This is well described in the literature. But however, actually in the clinical case, you see far more frequently this. What it is that outlet septum and aorta and pulmonary trunk move just forward as a unit. And then the outlet septum does not go to the margin of the VSD, but parallel with the rest of the VSD. And then you have subpulmonary VSD, and then subaortic outflow tract encroached on because it's pushing against the free wall. And then you can have coarctation of aorta, interruption of aortic arch, right? So what is the difference is that these two heart is different heart. If you look at here, this is a right ventricle, this is left ventricle, tricuspid valve, and mitral valve, and then no question, double aortic right ventricle. Outlet septum goes to the septum, right, vertically. And then VSD is here, making this VSD subpulmonary. What it is that starting point is TGA. If everything is the clockwise rotating, and then pulmonary valve, we're going to move forward, and then aorta stay there, and then VSD is here, and outlet septum goes to the right margin of the VSD. That is one way to make the double aortic right ventricle. I think already 15 years. Okay. So you can see the outlet septum orientation very well enough, right? The other way to make a subpulmonary VSD is that everything is moving forward. And then you have VSD leaving behind, outlet septum forward, and then outlet septum is parallel with the rest of the ventricular septum. So there are two different pathologic orientations. You can have a little bit of combined feature too, because in congenital heart disease, anything happens, right? But here is interesting. If you have here this mechanism, great arterial trunks will be parallel, right? Side by side. And then, if it is this mechanism, it is more maintaining the usual great arterial relationship of DTGA, complete TGA, or transposition, okay? So that is a little bit different. Okay, here is another one. Okay. If you look at this MRI, here is the aorta, here is the stenotic subpulmonary outflow tract. Can you see that the ventricular septum here swinging far to the left side, okay? In the short axis, so this is atrial septum, right atrium, left atrium. You have your ventricular septal remnant here. Below that, you can see the ventricular septal orientation is there, right? So atrial septal plane is here, and below, ventricular septal plane is there. So what it is that whole ventricular septum is malaligned away from the atrial septal plane. So here it is. So these are staying there, like in complete transposition, but the whole septum is away. What is going to happen? Anterior part of the mitral valve will be straddling, overriding, and then there is double aortic right ventricle. So this is different from the other thing. What is this? That other is that outlet is moved away from the rest of the septum. Here, making DORV, how? The whole ventricular septum is away from the rest of the atrial septal plane. So to make it everything here, so what happened is that starting from the transposition, what if we have your atrioventricular septal malalignment this way? You will have mitral valve overriding and straddling and double aortic right ventricle, and pulmonary valve will be close to the VSD. Okay? So therefore, you have your DORV, three different ways of making the VSD subpulmonary location. So here is that I've named as the flap valve mechanism. Outlet septum goes to the right margin and subpulmonary. And then here, outlet septum is parallel, all moved out, subpulmonary. Here, actually, outlet part is more or less okay. And then whole ventricular septum is clockwise rotated, leaving mitral valve straddling and overriding, and then outflow tract is different. I dare to tell you it's different disease. Why? You remember tau C being malformation, usually associated with subaortic obstruction and aortic arch obstruction, right? Coarctation of aorta or interruption of aortic arch too. But here, if you look at the literature saying tau C being malformation with mitral straddling, not associated with aortic outflow tract obstruction. More frequently, pulmonary outflow tract obstruction because mitral valve tissue is hanging around. So that's why I'm telling you this tau C being malformation and this so-called subpulmonary VSD, completely different pathology. Okay. Another is that this is I have agreement with Bob Anderson. What it is that he used to describe if you do not have outlet septum, that VSD is doubly committed. If you look at the figure in the literature, it's not doubly committed. Why? Pulmonary valve is away from the VSD. So only difference is what? Outlet septum is absent here, but however, VSD is subaortic. So this is the important one. So here you have two 3D printed model. Here, aortic valve, pulmonary valve, you have outlet septum, and VSD is here, absolutely doubly committed. But there is small outlet septum. But in this case, there is no outlet septum. Pulmonary valve is here, and the aortic valve is here. VSD is subaortic, okay? So here, the more convincing is here. Absolutely, you don't have outlet septum, aortic valve and pulmonary valve. VSD is remote, right? So absence of outlet septum in echocardiography especially does not really make you a diagnosis that you are with doubly committed VSD. No, 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 okay? So the next contentious topic is what? How do you define the remoteness of VSD from the arterial valves? Do you have any definition how to call the remoteness? I find that in the literature, only the surgical literature says that distance between the upper margin of the VSD to the nearby semilunar valve more than the diameter of aortic valve. But however, this is tricky. Why? What if you have a subaortic stenosis and aortic valve is small? You can't define this way, right? So again, remoteness is very arbitrary definition. If you look at the literature, interesting is that echocardiographic literature, remote VSD instance is far less. Surgical literature, far, far higher. Why? Surgeons, if they are not able to make it, they will describe remote VSD, right? So it's a very arbitrary definition. Okay. So here you can see that VSD predominantly inlet, and then you have a subaortic subpulmonary infundibulum, outlet septum is here, a little bit of subaortic stenosis. This VSD is definitely far. But however, when you have the unusual configuration, don't just say remoteness, but however, still you need to describe whether it is baffleable to the aortic valve or baffleable to the pulmonary valve, right? So here in this case, double aortic right ventricle, small pulmonary valve, okay? So inside, you have VSD, this is a medial papillary muscle of Lancisi. VSD is half below, half above. Medial papillary muscle of Lancisi has surgical implication. So there is an easy landmark to say the surgeon standing this side, if your surgeon's right-hand side to the medial papillary muscle is more inlet. If it is on the left-hand side, it is outlet, right? So this VSD is 1/3 inlet, 2/3 outlet, right? But however, it is remote from the aortic valve. By definition, it could be easily described as the remote VSD. But however, to me, it can be easily baffleable to aortic valve, right? So in short axis, mitral valve, the tricuspid valve, mitral valve, aortic valve and pulmonary valve, outlet septum is here, VSD is behind this structure. Okay. What I did was that this is the same angulation. Graphically, we made the baffle, simulating baffle surgery, okay? So from the VSD going here, I was able to push a little bit so that tricuspid valve function should not be compromised at all. Okay? So in the short axis, so VSD is going to the aortic valve. This is a baffle. Actually, I brought the model here in the intervention that I can show you the model to you in this case. Surgery was not done yet. This is a case of it last week. I strongly recommend surgeon, you can do the biventricular repair. And David Barron agreed. Okay? So this is the surgical outcome. So right ventricle, left ventricle, baffle is quite long, but however, you can still make patent LV to aorta, and then rest of the right ventricle is large enough. Two things we need to look at. What is that? Whether baffle can be applied in a good dimension throughout, not compromising the tricuspid valve function significantly, and then because it uses up right ventricular volume significantly, what is the volume of the rest of the right ventricle? That should be really assessed. Okay? In that regard, the 3D modeling is very, very, very helpful. And then, that is what I was yesterday telling you, the kind of 5 features explained versus illustrated. So if I show this, surgeon will be more confident in what they need to do. Okay, let me go to here. So the other is that the extent of inlet extension will be an important issue. Okay, how do you define? Don't look at the 4-chamber view in echo. You need to look at the short axis view. How? Here you see the tricuspid valve and mitral valve in short axis. So this is the ventricular septum. VSD is here on top of the tricuspid valve, which means it's exclusively outlet. However, here, ventricular septum stops here, tricuspid valve halfway inlet. Here, more, okay? So in the movie, you can see exactly the same case. So this is how you assess the extent of inlet extension. Okay. A lot of time that the AVSD simply classified as remote VSD, that's wrong. How? This is the case with right isomerism. AVSD is really AVSD alone, and then it does not extend to the outlet, right? But however, similar pathology in cytosolitus, you have AVSD extending all the way up to the aortic valve, and there is subpulmonary obstruction. So what is that? This is AVSD with DORV tetralogy of Fallot type. So AVSD very often extend to the semilunar valves. Therefore, it should not be described as remote VSD. Okay. So therefore, what I'm proposing to you is fine. You define as a remote VSD. Always define whether it's not able to baffle to the subaortic or subpulmonary outflow tract. Remote, but still baffleable to aortic outflow tract. Remote, but still the baffleable to subpulmonary outflow tract. That is how fine-tuned for the classification of remote VSD. Okay. So this is what I was talking about, extent of infundibulum. Drawing is actually much easier. I intentionally made the inside of the heart exactly the same. What if infundibulum is short? What if infundibulum is long? Distance also depending on extent of infundibulum too. Therefore, you need to describe the extent of infundibulum. And then also great arterial trunks. Okay, so it is a little bit too complex. And then one thing that we can, as an echocardiographer or CT or MRI physician, we can give the information to surgeon is that, oh yeah, you can easily say your classification VSD type. It can be regarded as TOF type. It can be regarded as TGA type. It is remote VSD, but baffleable to aortic or pulmonary outflow tract. And then DORV with AVSD or no hope, single ventricle, okay? I want to stop here, and then there are some more additional features to describe, but however, this is what I find that not discussed thoroughly, so I present here, I stop here. Thank you very much for your attention.